For your patients with hard-to-control hypertension, are you struggling to achieve blood pressure goals despite treating with at least 2 antihypertensive medications? Uncontrolled hypertension increases the risk of death and stroke for many patients. Not all hypertension is the same. For many of these patients, you may want to consider a different pathway. Aldosterone may be to blame. Visit blamealdo.com to learn more.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. I'm Jenna Skowronski, chair of the CardioNerds Heart Failure Council, and I am so thrilled to welcome you to episode 2 of our Advanced Therapy series. In our last episode, we were joined by Dr. Michelle Kittleston to discuss the initial referral and workup for advanced therapies. If you haven't already, be sure to check that out. Today, we have our second episode of our Advanced Therapy series with a special guest who I am very fond of, in which we will be discussing the pre-transplant evaluation. We're again joined by Dr. Shazli Khan, current cardiology fellow at Westchester Medical Center in New York and future advanced heart failure and transplant cardiology fellow at Columbia. Shazli, I always love doing podcasts with you. Welcome back.
Thanks so much, Jenna. I'm so excited to be here and excited to continue to dive into the path of advanced therapies, and exceptionally excited to introduce today's fellow and training lead, Dr. Rachel Goodman. Rachel pursued her medicine training at Medical College of Wisconsin, where she served as chief medical resident and is currently a cardiology fellow at Tufts Medical Center. Rachel currently serves as a CardioNerds Academy house chief and has contributed to several podcasts and projects in the past. It's so nice to have you here. Welcome back, Rachel.
Thanks, Shazli. I am thrilled to be here today and to introduce our expert, Dr. Kelly Schlendorf. Dr. Schlendorf is at Vanderbilt University Medical Center, where she serves as the Director of Heart Failure and Transplant and is the Medical Director of the Adult Heart Transplant Program. Dr. Schlendorf completed her residency and fellowship at Johns Hopkins, followed by her heart failure and transplant fellowship at Duke University. Welcome to CardioNerds, Dr. Schlendorf. We are so thrilled to have you. I think if everyone's okay with it, we'll kind of jump into our case, a patient that we're rounding on in the CardioNerds CCU, Miss Takra Lee. She is a 55-year-old woman with chronic heart failure with reduced ejection fraction and ischemic cardiomyopathy, CKD2, and she is transferred to our unit from another hospital with AMI shock after initially presenting with an infero-posterior STEMI and development of progressive AMI cardiogenic shock. She has a history of CAD with a CABG in 2017, PCI to a vein graft in 2022, and to her left circ in 2023. At the other hospital, she had a left heart cath, which had thrombotic occlusion of the left main. This was stented with poor reflow to her left circ system. She also had a known CTO of the LAD. She had a patent lima to LAD, but all of her venous grafts are down. She had an echo that has an LVEF of 25 and evidence of papillary muscle rupture with severe MR. She had a right heart cath that showed an RA of 15, PA of 60/21 with a mean of 37, a wedge of 27, a cardiac output of 3.8, an index of 1.6 via FIC. On her labs, her creatinine is 2.5 with a known baseline of 1.2, and she had AST and ALT that were 2300 and 2100 respectively. She is transferred to our hospital with a balloon pump for consideration of advanced therapies. She has a BMI of 32. After 2 days of diuresis and dobutamine, her hemodynamics are as follows. RA of 2, PA of 38/12 with a mean of 21, a wedge of 10 with V waves to 15, and an output and index of 5.6 and 2.3 when the balloon pump is on standby. Her liver enzymes and her creatinine have improved to her baseline. However, when pausing the balloon pump to obtain hemodynamics, she had continued chest pain and clear EKG changes. After evaluation with CT surgery, it is determined that she has poor targets for a redo CABG and has no further options for revascularization.
Wow, what a dense and complicated case. So, Dr. Schlendorf, any thoughts right off the bat? How do you typically approach a case like this with this many intricacies? Let's say, assuming she is deemed to be a candidate for transplant after evaluation, which is discussed in episode 1 of the series. What are some things that you would consider in getting her to transplant?
Wow, what a great case. This is one that I think many of us have seen on replay over and over again in our CCUs. That is, a patient who presents with AMI shock, not amenable or responsive to revascularization, and who I think clearly has a poor prognosis absent advanced heart failure therapies. While this patient's hemodynamics have improved with a combination of temporary mechanical support, dobutamine, and diuresis, the fact that she has chest pain and EKG changes when the balloon pump is paused suggests ongoing coronary ischemia. And so for her, it would be very reasonable to maintain temporary mechanical support as a bridge to transplantation. And I should note, if the balloon pump has been placed femorally, to move it to an axillary site to really facilitate her getting out of bed and on her feet while she awaits transplant. Now, that being said, I think needless to say, remaining in the hospital on temporary MCS is not a free lunch. It puts patients at risk for nosocomial infections, including catheter-related bloodstream infections, for vascular complications, for bleeding, and for overall debilitation and malnutrition if we're not very intentional about physical rehabilitation and ensuring good PO intake. And so that being said, and depending upon this patient's anticipated waitlist time on balloon pump support, which varies from center to center and from patient to patient based on a number of different factors, an alternative strategy might be to consider durable mechanical circulatory support, in other words, an LVAD, as a bridge to transplantation.
Sorry, just taking a step back, I'd love to discuss some of the aspects of transplant that have huge impacts on our patients, starting with listing status. For those that don't know, listing criteria for heart trans is a status system that's meant to prioritize the sickest patients to be higher on the list, putting those who have lower short-term mortality lower on the list. Dr. Schlendorf, can you talk about listing status and priority? Where would our patient who is stable on a balloon pump be on the list? What if she was stable on a single inotrope?
Great question. The current iteration of the heart listing statuses was implemented in the fall of 2018 and was really developed in an effort to, as you said, assign the highest priority status to those patients deemed to have the highest estimated waitlist mortality, as determined for the most part by their hemodynamics, their need for temporary mechanical support and/or inotropic support, and also their need for hospitalization. So in this system, there are 6 active statuses. Patients listed status 1 are considered the most medically urgent, and those listed status 6 the least medically urgent. By way of a little bit more detail, the status 1 patient is generally in the intensive care unit with recent or current hemodynamics demonstrating cardiogenic shock. So hypotension, elevated filling pressures, low cardiac index, severe enough to necessitate biventricular, surgically implanted, and non-dischargeable support. In most cases, that's a patient on VA ECMO. The status 2 patient is similarly in the intensive care unit with recent hemodynamics demonstrating cardiogenic shock, but is able to be supported with univentricular temporary support. So by virtue of our patient's need for balloon pump support, the patient we're discussing would be listed as a status 2. Status 3 patients are typically defined by one of 2 things, either the need for hospitalization and high-dose inotropic support with an indwelling pulmonary artery catheter, or a patient on durable VAD support who is having a complication, for example, device infection or a GI bleed. Whereas patients listed status 1 and 2 are always in the hospital, and patients listed status 3 are sometimes in the hospital, patients who are listed status 4 through 6 are often waiting for transplant at home. The majority of status 4 patients are those who are stable on durable LVAD support, although this category also includes patients with certain diagnoses, for example, congenital heart disease or hypertrophic cardiomyopathy. Status 5 in the allocation system is reserved for patients awaiting dual organ transplant, so for example, heart-kidney, unless those patients meet hemodynamic or other criteria to afford a higher listing status. And finally, the status 6 patient is stable enough not to require any kind of inotropic or mechanically assisted support.
So, when listing a patient for transplant, there's a lot of factors that go into finding an appropriate donor heart. Things that this include are blood type, recipient height and weight, unacceptable antigens, anticipated ischemic time, and age of the donor and recipient. Dr. Schlendorf, can you talk us through each of these and how different factors impact wait times? Also, hoping that you can discuss a little bit about how geographic region impacts your wait time.
Sure. Perhaps not surprisingly, when we list a patient for transplant, one of the most common questions we get from them and their families is, how long will I wait? Needless to say, it's a bit of an unknown because unlike an LVAD, for example, we can't pull a heart off a shelf. And anytime a donor heart becomes available, it's really important to make sure that not only is it a good, well-functioning heart, but also that it's a good match for the intended recipient. So, as you mentioned, there are a number of factors that influence wait time and also decision making about donor offers. One of them we've already talked about, that is listing status. All else being equal, a patient who's listed status 1 is going to be transplanted more quickly than a patient listed at a lower status. Another important factor is blood type, because at least in adult heart transplantation, a patient must receive a heart from a donor with an ABO compatible blood type. As people may remember from med school, persons who are blood type AB are considered the universal recipient because they can receive organs from anyone with any blood type. Conversely, patients who are blood type O can only receive a heart from a donor who is blood type O. Persons who are blood type B can receive a heart from someone who is a blood type B or a blood type O, and the same goes for persons who are blood type A. They can receive a heart from another blood type A or from a blood type O. So given all of that, and because blood type O is the most common, in other words, most waitlisted candidates are blood type O, then all else being equal, patients who are blood type O tend to wait longer than patients with other blood types. Equally important as the blood group antigens in determining organ compatibility are the human leukocyte, or HLA antigens, which are found on the surface of most cells and play a role in the immune system's ability to distinguish self from non-self. Over the course of a lifetime, individuals may develop antibodies directed against certain HLA antigens. We call these anti-HLA antibodies, and patients who express detectable anti-HLA antibodies are said to be sensitized. Especially for patients who possess a lot of these antibodies, especially if at high levels, it can be challenging to find an immunologically compatible donor because we're having to wait to find a donor whose heart doesn't express the same HLA antigens to which the waitlisted candidate has antibodies. In other words, who doesn't express what we often refer to as the unacceptable antigens for that candidate. The more anti-HLA antibodies a waitlisted candidate expresses, especially if present in high levels and directed against antigens that are common in the general donor population, the longer their waitlist time will be. You also mentioned recipient height and weight. I won't go into great detail here, except to say that data suggests that donor undersizing, where the donor heart is significantly smaller than the recipient's, can be associated with worse outcomes for recipients. And so because of that, patients who are very tall or very large in other dimensions may have longer wait times. And then finally, geography indeed impacts wait time. The reasons for that are severalfold, but one reason is that under the current heart allocation system, when a donor heart becomes available, it's offered initially to candidates who are listed at transplant centers located within a 250 nautical mile circle around the donor hospital. And so as a result, candidates who are listed in certain metropolitan areas close to multiple other transplant centers and with reasonable proximity to the coast, for example, will have, on average, a smaller and more competitive local donor pool as compared to candidates who are listed at centers in parts of the country where there might be less local competition and a larger potential area of donor hospitals.
Dr. Schlendorf, thank you so much for that. I have a little bit of a surprise question. I heard you go through all of that, which was wonderful, and mention that in adult we have to match ABO, which would imply that in the pediatric population we do not. I would love to hear a very high level little clip about what that was implying for our listeners and honestly for myself as well.
Well, there's some data in the pediatric transplant literature suggesting that transplanting children with ABO incompatible organs may be possible, in part because children tend to have much less well-developed immune systems. And so this is actually done in the pediatric world. And there's some suggestion that with time and further research, it may ultimately become a possibility in adult heart transplantation. But I think we've got a fair amount of research and investigation to do before that reality
That's fascinating. Thank you. I think, I'm an adult cardiologist, as you all know, but I think that pediatric transplant is really fascinating, especially how the immune system is able to adapt and the heart is able to grow with the child that receives it. So thank you for that. And I will let Shazli get back to her question.
Yeah, thank you so much, Dr. Schlendorf. That was all very insightful. I know you touched on this a little bit regarding the unacceptable antigens, but I wanted to take a time to talk a little bit more about panel reactive antibodies, or PRAs. So going back to our patient was found to have 85% class 1 PRAs with 50% complement fixing and 40% class 2 with 10% complement fixing. I think you mentioned this, and I think many listeners are aware that it's necessary to match a donor to a recipient and have heard of patients being sensitized, as you mentioned, but we don't really know about the specifics that go into that. So, could you give a little bit more of a basic overview of PRA? Do we want them to be high or low? And what are some things that can impact PRAs and cause a patient to be sensitized?
Yeah, the immunology of transplant really is fascinating. As you said, we already talked about anti-HLA antibodies and the concept of sensitization. Sensitization really occurs as a result of what we often refer to as sensitizing events, events that expose the human body to foreign HLA antigens and prompt the immune system to develop antibodies that target those antigens. Most commonly, these events include things like pregnancy, obviously specific to women, as well as for all patients, exposure to prior blood products or prior organ transplants. Sometimes infections can lead to sensitization, as can the presence of homograft material. We see this commonly in many of our adult congenital heart disease patients. So, among the tests that we perform anytime we evaluate and list a patient for heart transplantation is a panel reactive antibody test, or PRA, which is essentially a blood test that assesses for sensitization. That is, it tests for the presence and strength of anti-HLA antibodies by mixing recipient or candidate serum with a panel of cells expressing different HLA antigens, and then measuring the percentage of cells that the serum reacts with. That percentage is the PRA. There's also something called the CPRA, or calculated PRA, which is similar to the PRA but is a calculated score that estimates the percentage of deceased donors a candidate would be incompatible with based on their reported unacceptable antigens, which are determined for each patient by their transplant center. So, for example, if a patient has a CPRA of 85%, that suggests that 85% of donors will be immunologically incompatible and only 15% of donors will be compatible. Needless to say, then, the higher the CPRA, the more sensitized a patient is, and the harder it will be to find a suitable donor. And the concern, of course, is that if we were to cross these antibodies when we accept a donor offer, that patient would be at risk for antibody-mediated rejection, graft dysfunction, and even mortality.
Thank you so much for that. That's so helpful. Immunology in transplant has been something I think that has probably been the biggest learning curve for me this year, and also the part of it that makes it so exciting that I'm going into this field. We have a patient who is highly sensitized. Desensitization is a podcast episode or 2 or 3 in itself, given its complexity. But in general, the goal for desensitization is to decrease the number of circulating unacceptable HLA antibodies, to increase the number of acceptable donors, and also to minimize the future antibody-mediated rejection risk. So, Dr. Schlendorf, can you give us a bird's eye view, very broad overview of the process of desensitization? And when would you pursue desensitization therapies? Maybe what are some examples of the protocols? And then we have a patient who's highly sensitized, but also as a status 2 patient on a balloon pump. So is that something that you would pursue for this patient particularly?
Well, as it relates to heart transplantation, desensitization is what you described, an attempt to reduce or remove anti-HLA antibodies in the waitlisted candidate in an attempt to increase that person's donor pool. Generally speaking, this process is reserved for highly allosensitized candidates, and it's often pursued only at larger volume centers that are willing to consider these candidates and have some experience with desensitization. There's really no one formula for this process. In some sense, I think it's still more an art than a science. But desensitization therapies often consist of some combination of things like plasma exchange, IVIG, and anti-B cell or anti-proteasome therapies, including rituximab or bortezomib, that really target the components of the immune system that are involved in creating the antibodies themselves. In thinking about the patient who we're discussing today and her candidacy for desensitization, it's a little bit of a tough question to answer. I'm grateful to practice at a large volume center with a reasonably large donor pool by virtue of the kinds of donors we consider and the distances we're willing to travel to recover hearts. So at Vanderbilt, it would be well within the realm of possibility that we would find a suitable offer for this patient without any desensitization. And I'd be inclined to just list her status too, cross our fingers, and wait. That said, if we were to pursue desensitization, then the therapies we administer could take as few as several days to administer or longer. The important point being that just because we pursue these therapies doesn't mean they'll be successful in reducing or removing circulating antibodies. There's really no guarantee that these therapies will facilitate a faster transplant. I think the other important point to keep in mind is that because desensitization involves immunosuppressive therapies, it generally puts patients at increased risk for infection or for cytopenias. And that's especially relevant in a patient like the one we've talked about who's sick in the intensive care unit and has probably any number of indwelling foreign objects in her body. And so some centers might decide to forego desensitization attempts in this particular patient. And if her anticipated wait time is therefore expected to be long, to pursue durable LVAD as a bridge to transplantation.
Wow, thank you. I think that desensitization is something that is complex and changes at different places. And it's always nice to hear this bird's eye view of things to consider. Moving forward, I think one important point that's relevant to listing that we had initially skipped over is donor selection in this era of an expanding pool of donors. So let's start by talking about DCD versus DBD. Dr. Schlendorf, I know that you've done a lot of work in this area. Are you able to talk to us about this and as well as special considerations with DCD donation?
Sure, the DCD topic could probably be a podcast in and of itself, but I'll try to keep my answers brief. So, important for listeners to know both brain dead donors, DBD, and circulatory death donors, DCD, have suffered some kind of devastating neurologic injury that is felt to be irrecoverable. And so their next of kin have made the decision to proceed with organ donation. The difference is that DBD donors have met the requirements for legal declaration of brain death, whereas the DCD donors have not. And so, as such, the process of organ recovery differs between the two categories. In the DBD donor, because they've been declared brain dead based on neurologic criteria, life support is able to be continued right up until the point of organ recovery. The heart is explanted at the donor hospital and generally placed either on ice or increasingly using some form of hypothermic storage that's a little bit warmer than ice, and then it's transported back to the transplanting center for the transplant to take place. In the DCD donor, the circulatory death donor, because brain death criteria have not been met, organ recovery can only take place once death is confirmed based on the cessation of circulatory and respiratory functions. And so in these donors, life support is withdrawn, and it's only after the heart has stopped beating and that any spontaneous respiratory function has ceased that the patient is declared dead. Following declaration of circulatory death, there is generally a brief standoff period of about 5 minutes, and only after that time point is the recovery process able to commence. And so in these cases, the donor heart and other organs are subjected to this period of what we call warm ischemia during the time that blood flow is reduced or stopped and before organ recovery takes place, potentially negatively impacting graft quality. So among the things that my surgical colleagues and I think about when we consider these hearts is whether that period of warm ischemia is so long that it's too long to safely move forward with transplant. There have been a number of studies published over the past several years that have explored recipient outcomes based on DBD versus DCD donation, including one that was published by our group a couple of years ago, where we essentially demonstrated, based on our single-center data, non-inferior outcomes, including incidence of severe PGD and 1-year survival, among a cohort of patients transplanted with DCD hearts as compared to those transplanted with DBD hearts during the same time frame. But because I think the field of DCD heart transplantation is still somewhat in its infancy, I think we still have a lot to learn about the longer-term outcomes after using those hearts.
I'm going to pop in for our listeners really quickly. Dr. Schlendorf mentioned PGD, and she was referring to primary graft dysfunction. So whenever the patient comes out of the operating room and the heart right off of the bat is having some form of dysfunction. I'm not sure that I would have known what that was last year. So just a quick explanation about that.
Yes, thank you for clarifying.
So, hoping that you can also clarify something else that I would say fairly new, which is transplanting hearts from Hep C positive donors into Hep C negative recipients. The other thing, kind of along similar lines, is transplanting from HIV positive donors into HIV positive recipients. So, both of these, I would say, in the scheme of transplant, are fairly new, and hoping that you can kind of discuss these efforts to expand the donor pool.
Yeah, I think both are interesting stories, and I think a nice illustration of how organ transplantation can sometimes interact with other areas of medicine and scientific discovery to really yield good outcomes and move the field forward. So, the Hep C story is a little bit near and dear to my heart. It used to be the case in the early 2000s that several studies had demonstrated an association between donor hepatitis C positivity and poor post transplant outcomes. And so, really, as a result of that, for nearly 2 decades, hearts from HCV positive donors were routinely refused for transplantation. And then, beginning in about 2014, a number of new drugs referred to as direct acting antivirals were introduced for treatment of hepatitis C. And concomitant with that, potential organ donors started routinely being tested for the presence of HCV infection using nucleic acid testing. And so these two developments really prompted the transplant community to re explore this potential donor pool, that is, donors with hepatitis C infection, the population of which has really grown dramatically over the past several decades as a result of the opioid epidemic. And so, whereas it used to be the case that we would never consider these hearts for our waitlisted candidates, beginning in about 2016, Vanderbilt was one of a handful of centers that really started to pioneer this strategy. We started taking these hearts for consenting patients, educating them that they might well develop hepatitis C infection after transplant, and they did. And then we went ahead and treated them following transplant with the direct acting antiviral therapies, which, again, exceedingly successful in treating hepatitis C and also very well tolerated by our patients with very few drug-drug interactions. And so, in many ways, this is one of the things that significantly allowed us to expand the donor pool beginning now almost 10 years ago. The HIV story is somewhat similar, although in the case of HIV donors, these are only considered for waitlisted candidates who are HIV positive, and really only at centers adhering to the guidelines set forth by the HIV Organ Policy Equity, or HOPE Act. But I think particularly for waitlisted candidates with HIV, this holds a lot of promise for expanding their donor pool.
Wow, we've really reviewed a lot today, from listing status to donor selection and patient factors that may impact waiting times. Dr. Schlendorf, thank you so much for your time and for teaching us today. What would you say are your main takeaways for the cardio nerds?
Well, thank you again, Shazli and Rachel and Jenna, for the invitation. Yes, we've definitely reviewed a lot. I think there are probably several takeaways. The first is that in the current iteration of the heart allocation system, there are 6 active waitlisted statuses, with each status defined using criteria that are really meant to reflect a patient's degree of medical urgency. Those of us who care for patients awaiting transplant spend a lot of time thinking about the most appropriate waitlist management strategy, recognizing that while the current system isn't perfect, it's what we've got, at least for now. The second takeaway is that waitlist status is just one of a handful of factors that influence wait time. And among the other important factors that we talked about, high levels of anti-HLA antibodies can really impact wait times, even in patients listed at a high status. For some very highly sensitized patients, these antibodies may ultimately make heart transplantation near impossible. So I think it's fair to say that the field of desensitization, at least as it relates to heart transplantation, is still somewhat in its infancy. And then finally, although it remains the case that in any given year, the numbers of patients awaiting heart transplant far exceeds the number of available donors, we've made major strides just over the past decade in exploring and finding ways to expand the donor pool, including things we talked about, like hepatitis C donors and more recently, DCD donors.
Yeah, I completely agree. And I think as someone entering the world of advanced heart failure and transplant next year, I can say there's a lot that has me excited about this field. What would you say makes your heart flutter the most about organ transplantation? What are you excited about for the future?
Well, first of all, I hope my heart's not fluttering. I'd prefer to stay in sinus. But that aside, what makes me excited about this field and really the future of this field is that it continues to evolve and to evolve rapidly in ways that I hope and think will not only allow more patients who need heart transplantation to achieve that promise, but equally importantly, to have good and better outcomes thereafter. And so, while it's much too early to know, one of the things I'm excited about is some of the novel strategies that are being explored right now for preservation and storage of donor hearts. We didn't talk about these, but I think these are strategies that may not only have positive impacts on immediate perioperative outcomes, but also on longer-term outcomes, like whether or not patients go on to develop allograft vasculopathy, which is a common complication that occurs after transplant. I'm also hopeful that work being done at many centers right now, including ours, will shed more light on the underlying gene pathways that are or aren't expressed in transplant recipients who go on to develop certain complications, and that this in turn will ultimately inform better personalization of immunosuppression and better treatments overall. So, having been a part of this field for over a decade now, I can confidently say it's incredibly humbling to be a part of, but also incredibly rewarding. And I really hope that some of the listeners of this podcast will decide to pursue this field. We need your talent and your curiosity and your expertise. And I promise if you choose this field, it's not a decision that you'll regret.
Dr. Schlendorf, thank you so much for joining us for this episode. It is my joy to get to share with the CardioNerds listeners what a wonderful educator you are and some of the amazing things that I've had the opportunity to see our center do. I hope to our CardioNerds listeners you enjoyed this episode. There is so much more to come in this series. We are grateful that you are here, and we are so thrilled to be able to share our amazing field of heart failure with you. So thanks so much.
Thanks for having me. I enjoyed being here.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marques. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.